Okay, so in 10 minutes or less, I'm going to give you everything you need to know about management of severe colitis. So we've heard about the case, patient who was originally managed with 5-ASA, moves on to steroid therapy, and then develops symptoms of actually severe colitis with elevated temperature, multiple loose bowel movements, with bloody bowel movements more than 10 daily. You evaluate her, do the really essential test here. Initial test is really excluding C. difficile and enteric pathogens. So these are her admission x-rays. A radiograph, a plain film, can tell you a lot, and a good radiologist will tell about mucosal involvement, can tell whether the patient has pancolitis, but we should do a limited endoscopic examination, and you see her views here with stage 3 Mayo Clinic score colitis. So a lot of we've learned about severe colitis started back in the 50s in England, and this True Love and Wit showing the criteria that you all use to assess patients. And really they're signs of systemic illness, and interestingly, the more that you have of these, the worse you do. So this is a study published some years ago looking at, there's really a linear relationship to colectomy risk with the number of factors that you have. And I'm not going to go through the factors because they're familiar to all of you. Really, standard medicine, medical management has been really the most important advance in this field. And remember, this was an illness that 40 years ago had a 30% mortality rate. So it's really important that you get this right. Hydration of the patients, initiation of corticosteroid therapy. It really doesn't matter which steroid you use, whether hydrocortisone or methylprednisolone. Personally, I prefer methylprednisolone because it's less likely to induce hypokalemia. Culturing the patients, stopping perpetuating agents such as antibiotics or NSAIDs. And really one of the pillars of modern management is the recognition that these patients are at high risk for thromboembolic disease and prophylaxis thereof. So I'll come to that later. And then you really have to monitor these patients in hospital. You have to show up and put your hands on the abdomen once a day, or otherwise you can have unpleasant surprises. If they're on high-dose steroids, they can mask intra-abdominal perforation and problems that way. And then I've alluded to a flexible sigmoidoscopy to stage the illness, and importantly, liaison with your surgical colleagues. So all these patients should be seen by a surgeon. Okay. So this is the, okay, we sit back. This is the Mayo Clinic score, and you can use this essentially in these patients. Most of these patients will have Mayo 2 or 3, and more importantly, beyond the Mayo score, if you have severe deep ulceration, such that you're seeing down to muscle, that is a very poor prognostic factor, and so it's really valuable to perform a flexible sigmoidoscopy, to get biopsies to exclude CMV, and to stage the patient and get a sense of what you're dealing with. This is the foundation of medical management. This is the second randomized controlled trial performed in clinical medicine, True Love in 1955. The British MRC trial of streptomycin for pulmonary tuberculosis was 1949. And this really changed the landscape, and steroid therapy is really fundamental. It saves lives. I mentioned thromboprophylaxis, and this is an article by Granginol in The Lancet. And it's a really important article, I think, to read, because a lot of my colleagues, there's two issues here, would say, well, Brian, I've never seen a sagittal vein thrombosis or a significant pulmonary embolus, and I've treated lots of these patients. Well, if you go to this table and you look at the incidence rates, what you'll see is the incidence rate in hospital is about 3%. And it's lower with ambulatory patients. But it's grossly elevated beyond garden variety surgical post-surgical patients. It's a really significant factor. And if you think about, you can use the old rule of 3 to actually illustrate this problem. So if something has an incidence of 3%, in order for you to see an event with 95% confidence, you'd have to evaluate 3% is 0.3 divided by 3 ends up 1,000 patients. So, you know, in your clinical practice, you're not going to see this, but if it occurs, it's a disaster. And it occurs in ambulatory patients as well, and it's controversial whether we should be prophylaxing them. But certainly you should give heparin therapy to these patients. So our patient, we start on methylprednisolone, do the usual things, and She gets the inevitable CT scan, which confirms what the plain film showed, that she had pancolitis. 9 bloody stools. CRP's high, that's not a good sign. And so what next? Well, rescue therapy. So this, when are you going to use cyclosporin or infliximab in these patients? And the important point is we have a couple predictive models for this, the Oxford Index originally, and then a refinement, the Edinburgh Index. And I just say that it's really simple. If the patient after 3 days is still having lots of bloody bowel movements, use an arbitrary number of 6, or the CRP has not come down with steroid therapy, that's a very bad prognostic sign, and you should be thinking about transitioning to rescue therapy. So here are the choices. This was the historical choice, cyclosporin, and I'll never forget this study in the New England Journal of Medicine because this was an N of 20 study, and it appeared in the same issue as our cyclosporin study in Crohn's disease, where we evaluated 305 patients for 18 months. So guess which trial got the result? Positive studies are better than negative studies, actually. So this study really changed global practice and was very de rigueur starting 20 years ago, but no longer is the standard of care. We've come to understand that you don't have to give the cyclosporin doses that were used in the original Lich-Digger trial. That was 4 mg per kg. You can give 2 milligrams per kilogram, and this is safer. Now, one general comment I would make about cyclosporin as a therapy, every case series of more than 50 patients always records a fatality. So this is, and it's usually due to infection. So this is something that can be used, but the toxicity is an issue. And that raises, in modern times, we've moved on from this to infliximab, and the original paper was by Yannerone colleagues in Sweden, betamethasone versus hydrocortisone, betamethasone monotherapy versus a combination with cyclosporin, and the cyclosporin patients had lower colectomy rates and really changed our thinking. Now, just recently, we've come to understand that the patients in hospital are really the problem children with regard to pharmacokinetics. These folks have very high drug clearance. They're the worst of the worst because they have, in distinction to what the basic scientists had told us for 20 years preceding, they have lots of TNF and a huge amount of antigen sink to overcome with your drug, so you have to give lots of drug. They're losing drug into the gut as an atypical mode of elimination, and this can be very difficult to overcome, and in some patients you'll have to use a small molecule to do that a monoclonal antibody just won't cope with this. It's why they have low albumins, why they have low globulins, they have low drug levels. And then they clear drug in the liver and spleen very rapidly because they're inflamed. So this is a real problem. So to overcome that recent popularity of giving accelerated dosing with infliximab, multiple dosings, collapsing the dosing schedule. And there are some data to support this practice. Is there a high-quality randomized controlled trial that shows benefit for this? No. And I think we should all bear in mind, too, that there are some individuals that you will not be able to overcome just by giving more drug. And it's, I think, a question in many of our minds is, can we recognize these patients early, and are these patients that we should be considering cyclosporin, going back to cyclosporin, or using some of the newer small molecule agents such as tofacitinib? There are no data with regard to either of those approaches or selecting the patients, but this is something that we're thinking about in modern times. This is the ECHO statement. Essentially says you can use either cyclosporin or infliximab, but do it early. And so in this case, we do have a comparative effectiveness study run out of France. And this is really quite a remarkable study in its size. It's over 100 patients for this condition. That's really as good as it gets. Comparing after 5 days of steroid failure, cyclosporin directly to infliximab. And you can see this is not a properly designed non-inferiority study, which would require 300 or 400 patients minimum, but it's pretty good for clinical rule of thumb. It does not appear to be much difference, and so as a lot of you have recognized, this infliximab is a much easier drug to use than cyclosporin. So it's pretty much, and this is just colectomy-free survival from that trial showing no difference. And the safety was not much to choose either. So the takeaway message from the medical side is don't use sequential therapy, that essentially adding multiple rescue therapies just increases the time on drug therapy, and it's problematic. So going back to this case, we have successful initiation of infliximab, and the patient did quite well, as evidenced by her CRP reduction and clinical improvement. You can use CRP. It's a very effective biomarker for TNF because it drives IL-6 production, which in turn drives CRP, and CRP has a very short half-life. So this is a very dynamic marker. If you see the CRP coming down, you're winning. If it's continuing to stay up or it rises, you don't have adequate control of the process. I'm not going to talk, we have an expert in surgery in this condition, and we'll discuss this in the panel condition. I'll just make a couple comments here, is that the longer you wait, higher mortality rates with surgery. So don't extend therapy into 2 weeks in these patients, because this is the price you pay. And the second concept is that if you're going to have a colectomy for severe colitis, you're far better off in a high volume center than a low volume center. And that's true for many surgical conditions. So I think I've just given you the brief tour. I've given you criteria for defining the disease. If you have multiple criteria, the worse you are, the higher your morbidity is. And the point, if you're going to use salvage therapy beyond corticosteroids, you use it at day 3. And you can, in the modern era, we're increasingly using infliximab and recognizing that many patients will require more intensive dosing than the standard 5 milligrams per kilogram. Thank you.